Hello everyone, hope you're well. David Johnson here. Just a quick video about surgical procedures today. Surgical procedures that we perform on the lumbar spine. Now they really fall into two categories: decompression or stabilisation, or sometimes both. That's what we're going to talk about today, in particular in relation to low back pain, where the ultimate pursuit is stability, and you're either going to do that with a functional intervention, optimal rehabilitation that gains stability of the lumbar motion segment. If that fails, surgical intervention, and here we are performing a stabilisation procedure, and this is called an artificial disc replacement. And I thought I'd just talk about the differences between an artificial disc replacement or a disc arthroplasty versus a lumbar fusion. Now, the most important thing that you understand is both of these surgeries have the same goals: motion segment stability, and as you know, that's exactly what NeuroHab does as well. Only NeuroHab can do it without surgery. So here is the surgical technique for a disc arthroplasty. It always has to be done from the front of the spine. So what this is showing is the front of the lumbosacral spine, and you can see there the sacral promontory and the bottom of the L5 vertebra. And this is clearing out the disc space and then inserting a spacer and then inserting the disc prosthesis. This is called a posterior lumbar interbody fusion. It's different in the fact that it fuses the spine and it's performed from the back. So here you can see the incision that's performed in the midline over the segment that requires the fusion. Here's the insertion of the pedicle screws. They can be inserted via keyhole incisions off to the side. And here you're removing the lamina, the posterior elements of the lumbar spine, which then exposes the neural elements. You gently shift the thecal sac to one side, and then you perform your discectomy, and that allows you to insert bone graft material in the intervertebral space, and that is what we refer to as a spacer, or sometimes it's called a cage. And you can see there that the neural structures are pretty close by, and they need to be protected during the surgery. And then often you'll put another spacer on the other side, and then you'll fill that space with more bone graft, which then creates a nice surface area for interbody fusion. So once the pedicle screws are inserted, a rod is traversed, and that acts as a scaffolding that holds the segment in place whilst the fusion occurs over the ensuing weeks. I hope they made sense to you. The take-home messages are fusion and disc arthroplasty have the same objective. Both of them are trying to achieve stability. A disc arthroplasty has to be performed as an anterior approach, whereas a fusion can be performed purely from a posterior approach, and you can perform a fusion from an anterior approach. You can also perform it obliquely, you can perform it from the side as well. They have different names, and the goals are the same: stability. There is fairly significant risk factor differences between coming from the back versus coming from the front. Although those animations seem quite simple, in fact it's not that simple during surgery. There are a lot of delicate structures that can be injured during those procedures. In terms of absolute risk, I would still say that performing surgery from an anterior approach is substantially riskier than from the back, and the major reasons for that are major bleeding from the large veins that are down in the pelvis. You also have significant autonomic nerves which are present in front of the vertebral column, and those nerves can be affected as well, and they can certainly affect autonomic function of the urogenital system, and so that can cause significant morbidity if those structures are injured during the surgical procedure for back pain, and those can be more debilitating than the back pain for some people. So I would always err to do the procedure from a posterior approach. And when you're choosing, should I have if I'm going to have surgery and a stabilisation surgery, should I have an artificial disc replacement versus a fusion? There are a few factors to take into account. You've got to ask yourself, okay, about the risks and what are the real or theoretical risks of going anteriorly or posteriorly. What is the advantage in a artificial disc replacement versus a fusion? And to my mind, there really isn't too much advantage at all, if any, of having an artificial disc replacement. Are there disadvantages? Yes, I think there are significant disadvantages. We've already talked about the risk of going from an anterior approach for an artificial disc replacement. Severe bleeding and death. I have not heard of a death from elective surgery from a posterior approach ever, at least in my surgical community, but I certainly have heard of on-table deaths from anterior approaches, just from uncontrolled bleeding, as well as lots of other really horrendous complications. And then there are disadvantages in addition to that, in terms of ongoing pain that may be driven by over-articulation of facet joints that may be arthritic as well, and then you've removed a degenerate disc and then put a prosthesis in that allows a lot more movement, and then you've got these facet joints at the back that can then become pain generators. And I've certainly heard of people having artificial disc replacements and having those disc replacements subsequently fused with pedicle screw fixation or conversion, removal of the disc replacement and converted into a fusion. So there's some disadvantages. And the reported advantages of motion preservation with the disc replacement, I think they're really overstating that simply because the prosthesis has some movement within it. I don't really believe that is a significant advantage. The reported advantage is that you're offsetting adjacent segment disease by allowing motion at one level and therefore not having the load transference to the adjacent segment and therefore preserving the adjacent segment. If that is the argument for an artificial disc replacement, it really just means that the reporting person, the person who's stating that, or the organisation or the company that's selling the prosthesis doesn't understand functional movement proficiency, because when we create stability, we're going to also create functional stability of all the segments through high quality bending biomechanics after surgery. So if that is the case, if that's the premise that that's necessary after every surgery, you're going to train your patients to have good biomechanical movement proficiency for bending, it makes absolutely no difference then whether you receive an artificial disc replacement or a lumbar fusion. So that's my take on it. If you've got any questions or queries, interests, hit me up in the comments and I'll try to get back to you. All the best. Bye.